Hi guys, this is Rowan with Sandstone Care. This is our second video podcast interview, and I am very excited to have Brandon with us. He is one of our clinicians. I'll let him tell you what he does here.
I'm Brandon Pruitt. I'm a licensed professional counselor and certified addiction counselor, and I am one of the senior clinicians for running the young adult groups, which meet 3 times a week, and then I co-facilitate the partial hospitalization program. That's our day treatment when we have clients in that level of care.
Okay, cool. How did you start? Because I know you've been with us since the very beginning.
Right. I was a contractor at the beginning when we opened the doors 2 years ago, and have come on full time in the last year. And so I've spent the majority of my career, which has spanned 22 years, working in acute psych hospitals, medical centers, mental health centers, pretty much every different facet of behavioral health I've had my toe in the water for. And so I come from a trauma background, working with people who are acutely distressed and maybe in crisis, I guess is probably the best way to put it.
Yeah.
Suicidal, homicidal clients, psychiatrically destabilized, and trying to help them really save their lives. And so I've done a lot of involuntary work where we're restricting their rights, we're holding them against their will just because of the nature of their psychiatric presentation. And part of my desire in coming to Sandstone and helping partner with the founders was to get upstream and try to get ahead of this before the client is literally dying from an overdose and we're having to bring them back, or they're locked in a room tied down to a bed because they're so out of control behaviorally. So Sandstone represents a great opportunity to really meet young people where they are and get ahead of the addiction before the destruction gets too serious.
That makes a lot of sense. And you mentioned too that you have seen a lot of clients who are coming in with a lot of trauma as well. And I know that you've trained in EMDR and you offered that for our clients. And I've been dying to know, just personally as well, a little bit more about that. And so I'd love if you could just tell me and our listeners about what EMDR is and why it's a useful modality.
Sure. I think the key concept is to understand that trauma is not always what we think it is. Okay. Trauma comes from a Greek word that really just means wounded. And so when people ask me, are your clients traumatized? I would say that they all have some level of trauma, whether it's a motor vehicle accident, a breakup with a girlfriend, it could be a combat experience if the person's from the military, it could be a death. But it doesn't have to be always that sort of what we call capital T trauma, like a rape or something of that nature. It could be simply, I was bullied in school when I was in 5th grade, and it was an isolated incident, and I never had anything else happen, but that's considered a trauma. And so it could be almost anything that causes a wound to the client. And so when people say, yes, is there a high percentage of your population that's traumatized? I would say absolutely, but it's only because my definition is broad to look at every aspect where a client has been wounded, rejected, abandoned, they've suffered loss or grief. It's part of the human condition, really.
Yeah, it's hard to get through life without
it really is. You're going to have a trauma
wounded.
at some point. And so that being said, EMDR really stands for eye movement desensitization and reprocessing, and it was a technique developed in the late 80s by Francine Shapiro, who in her doctoral work realized that while she was exhibiting anxious symptoms, she noticed that moving her eyes across the midline of her face out in space could create a great reduction of that anxiety. And she felt like, I think I've stumbled onto something here. So the technique is really based upon rapid eye movements and or tactile stimulations that are bilateral, left to right, again across the midline of the face, that then helps the brain reprocess information. So in EMDR, trauma and all psychopathology is really looked at in one way, and that is that mental health symptoms, psychopathology, is related to maladaptively encoded memories, meaning that these memories get trapped in a cycle, in a loop, and they are causing the vagus part of the nervous system to either be overactive or underactive. Okay. And so the patient, this is where the patient experiences the distress, Rowan. They're either paralyzed or they're in fight or flight. And so everything is all out of control at that point. So the key piece for the clinician is to assess what's their window of tolerance. Is their cup too full? Are they suicidal? Are they highly self-destructive? Maybe are they prone to self-harm behaviors? Are they psychotic? Is there processing in reality? Are they dissociative? If any of those apply, EMDR is probably not a good introductory technique to use. Right. But once we've ascertained that, and there's certain scales and packets of information that we will give to clients to assess them for their readiness, and then once we've decided, okay, they're an appropriate fit for EMDR, we'll begin the process. So what really happens is we lead them into accessing a target memory. Okay. That memory represents a snapshot in time of, let's say, the car accident. Okay. The person will recall that with guided imagery from the clinician, which, by the way, is really kind of minimal. We want the client to experience this with just some minor help from the clinician, and that is, okay, I reprocess, or I'm accounting to the motor vehicle accident, reliving that for a moment, and then we ask them some basic questions. What are you feeling in your body? Because trauma by nature is a somatic piece, not just a mental piece, but it is somatic. So it basically affects the body. Yeah. So someone, for example, who's reliving the car incident would say, all right, I'm feeling the jar of the crash. I'm feeling the tension and the pain in my neck. And so literally years later, this information can get stuck in a maladaptive encoded memory, and thus this is what we're trying to target with the EMDR. So once we know what those sensations are like, what those thoughts and negative cognitions are, we actually then begin the bilateral stimulation I use a combination of eye movements and tactile stimulation. I have some pulsars that give a small vibration to each of the hands. I'll have them hold the fobs, and while they have their eyes closed, they're actually feeling the sensation left to right. It's not important that they notice that so much as just really give themselves over to the experience. The bilateral stimulation will cause the brain to reprocess the information and link with the adaptive information processing centers of the brain that are essentially offline during a trauma event.
Right.
And so that's the key piece of the healing. We notice under brain scans that some of the frontal lobes are actually inactive when a person's in trauma, and we can see most of the activity stuck in the right hemisphere. So the bilateral stimulation, Shapiro found that the left hemisphere is able to actually reconnect with the right and communicate more effectively. The information is reprocessed, and then the person will notice over time with several sets of the bilateral stimulation that they feel much less anxiety, for example, tension. The somatic symptoms will begin to decrease rapidly, and overall, that's how we know we're making the progress. In addition to that, there's some resource installation that is involved, and that is to have them go to a safe place where they can ground themselves in okay, I'm in that moment with the car accident, but I'm going to move to grandma's porch where I always feel safe for a moment, allow that somatic tension to dissipate a little bit, and then move them back into the memory once they're safe to do so. And over time, we can lessen the subjective units of distress, and we measure that out of a 10-point scale. We'll say, okay, how distressed are you? I'm a 9 out of 10 right now, but over maybe say several sets of eye movement and tactile stimulation, they will report, I'm feeling less anxious, I'm feeling less distressed, the panic is gone, and we'll close the session once we've decided they're in a safe place and we have resolution basically of most of that traumatic material. What's fascinating, Rowan, is that for single incident PTSD, like a car accident, if that was the trauma and there's no chronic repeat of that, the effectiveness of EMDR is between 75 and 100% remission rate.
Wow.
It's
that was going to be my next question.
It is unbelievable, and in my practice, I've seen great strides being made by clients who are stuck in that spot and can't seem to, even with lots of psychotherapy, medications, and so forth, they just cannot seem to get past that woundedness, where the trauma is stuck. The EMDR helps uncouple those memories and activate their adaptive information processing so that they're not forgetting what happened, but just when they recall it, that impact, that negative, harmful impact of the trauma is no longer there for them. And again, what's most interesting for the addiction world is that those same protocols can be modulated slightly to affect cravings and triggers. So our patient population, which at Sandstone is principally substance abuse related,
right.
we will have them recall what it was like to use heroin for the first time. And most clients will then get very activated in a more euphoric way than negative. But those same memory networks are very similar to the trauma networks that we're accessing when they pull up like a car accident memory. And so then with the bilateral stimulation, we can uncouple the tie of that maladaptively encoded craving or trigger network and have their rational mind and those networks come into play to where they can then say, okay, the intensity of that craving is now much less. The more I go back to that memory of heroin, it's no longer activating that same memory. And so essentially what we're doing is really working on those reward pathways in that sense with the cravings and triggers, unlike the trauma memory, and we're helping them desensitize to that. And that's what we're really excited to bring to Sandstone, is that sort of craving piece, which in a sense, again, is a traumatic experience, just in the reverse. It's a euphoric one that overwhelms their brain, and the EMDR helps uncouple that and bring them to a point of stability.
Wow, that's cool. And so, so you talked about how it's especially effective in single, that would be the big T, like a defined traumatic event. But it sounds like it's also effective in those things where they were bullied or something. Right. There are other wounds that maybe aren't as defined as a single event.
Right, and so chronic PTSD, where there's been repeated physical abuse, domestic violence in the house, things like that can also be highly treatable with many sessions of EMDR. It's very principally tied to the rapport with the therapist. That's key. And then the ability of the client to process through some things with guided imagery. But it has been highly effective in almost every area that I've focused on with clients, whether it be anxiety, PTSD, depression, phobias. I would say that for the person with the car accident, there was a lot of times where they didn't want to go out and drive. So there was almost a paralysis or agoraphobia that kind of got installed because they were afraid that the next time they went out driving, they would get hit. So again, all of those things can be reprocessed with EMDR successfully, and helping the client gain a new understanding. The whole idea at the end of it is to not only help them feel safe in that moment without the distress, in recalling the trauma, but also installing a positive cognition in them. For example, I am worthy. Whereas they feel trapped or lonely or abandoned, then they would say, well, I never did feel the connection because I was abused, and I never felt the connection in my family system or with the bullying gang, and never felt like I was worthy. But if we can help them install that worthy idea, that cognition of I am worthy, we bilaterally stimulate those areas of the adaptive networks of the information, that is now their new installed idea about self. And so they're forming a positive neural connection. Their neuroplasticity is essentially really rewiring during that time, and they are having new pathways being formulated, and the adaptive ones that were offline before are now connected to something positive and wholesome as opposed to destructive. So we can help them understand. Again, it's not hypnosis at all. I know I was a skeptic, I have to admit that. People were asking me, were you always a follower of this? And in grad school, I felt like I didn't understand it well enough, and I was a skeptic. And so through the 125 hours of training that I just went through in the last year and a half, I've really become a great proponent and advocate for EMDR, because I've seen the fruit of what can happen in a session. Even here at Sandstone, remarkable success being reported by the clients as they go through this experience. And sometimes I can't always follow through with them through the whole course of IOP necessarily, because their time won't permit it. But at least we've given them a good introduction to the process, and they want to follow through with an outpatient provider that specializes in it.
That was going to be my question, because often people are only here for 8 weeks or so, and then they might continue with outpatient, but at that point they're not at a level of care where you can devote that much time to them. And so how do we connect them to? Because it sounds like sometimes it takes longer than we have.
It does. So at about the 3 to 4 week period of entry into IOP, we're already starting to try to connect the client with outpatient providers that we know are reputable. We don't simply pick from a list on the internet. We want to know these people. Right. So I have met and worked with many great EMDR clinicians in the city. And so then the task will be, where's the best geographic fit, where's the best personality fit of those people that we know and trust. And we begin to link them with that person well before they discharge from IOP. Now, at times, because they're full, we have to just ride it out and have them try to make an appointment. And that's where I can be helpful in bridging the gap by offering sessions while they're waiting for their first intake. Okay. But at least what I found is many of them are also frightened by the idea of participating in such a sort of what seems to be a radical type of therapy. But most clients come away saying, that was amazing, I want more of this. And so that's what we can do, is we can make that warm referral based on the outreach team and connections that we already have personally in the professional community.
Great. Well, thanks so much for explaining that. It sounds really fascinating. I'm really glad that we have that available for our clients. And I also just want to say, if you're looking for people to do EMDR with, then please reach out to us. As Brandon said, we have a network, and we're constantly growing that network to be able to connect people with really high quality options in the community. And so that applies to all of our locations, whether it be EMDR or other modalities that you feel like have been effective for you or your client or your son in the past or daughter, then we're happy to help you get in touch with those people, and we'll always do the best we can to make those warm referrals and not just pick a list off of an internet listing. So thanks so much for watching, and I hope you learned something. I know I learned a bunch. So thanks a lot, Brandon, and we'll be back soon with more.